Good afternoon and welcome to the third lecture in our neurology series. We will be continuing with our neurological localization. So in last lecture we have covered a case of hemiplegia with different case scenarios. So today we will be covering three more case scenarios. The first case scenario will be a patient with a numb hand. A numb hand. World over, this is a very common neurological problem, and numb hand is primarily caused by carpal tunnel syndrome. So one of the most important cause of numb hand is carpal tunnel syndrome, wherein you have involvement of medial nerve in the carpal tunnel and there is a focal conduction block, and that causes symptoms. But what are the predominant symptoms? Are usually numbness. You have numbness, and one of the most striking feature of carpal tunnel syndrome is nocturnal awakening. Patient will predominantly have a complaint of nocturnal awakening due to pain and numbness. This is pathognomic of carpal tunnel syndrome. So what happens in basically carpal tunnel syndrome is you have involvement of thumb, first forefinger, middle finger and half of the ring finger. But patient generally doesn't present to you like that my 3.5 fingers are numb. He'll generally report as a thumb being numb, or he'll say my whole palm is numb, because he has not read his books wherein you have distribution of median nerve which is very well written. So a carpal tunnel syndrome patient will come to you with either one or whole hand numbness, right? Weakness is not the predominant feature, means the power remains good. Power remains good. In a prolonged case of carpal tunnel syndrome, you can have atrophy of the muscle supplied by the median nerve, right? One important differential diagnosis for anyone having carpal tunnel syndrome is ulnar nerve involvement. Ulnar nerve involvement. Ulnar nerve involvement again can cause numbness of ring finger and little finger along with weakness, right? The major differential point is that ulnar nerve predominantly cause weakness of hand muscles, right? Whereas median nerve causes numbness. So sensory symptoms are predominant in median nerve, whereas motor symptoms are predominant in ulnar nerve. And mind you, ulnar nerve doesn't gets affected in the wrist, it majorly gets affected at your elbow. So patient with ulnar nerve problem can present you with numb hand, but there will be profound weakness of hand muscles, whereas in median nerve you have profound symptomatic symptoms rather than weakness. The other differential diagnosis for a numb hand would be anyone having C5 to C7 radiculopathy. Why this is important? You have distribution in your hand by C5 to 7. So any radical can give rise to radicular pain and sensory symptoms in your hand. So how do you differentiate? Suppose you have C6, C7 nerve root problem. So what happens to your triceps reflex? Tricep reflex gets absent, because whenever you have a root problem, it's an element problem, right? Element problem will give rise to absent reflex. So in carpal tunnel syndrome, you have presence of tricep reflex, whereas in C6-7 radiculopathy, in which you have similar symptoms, you have absent tricep reflex, whereas bicep and brachioradialis are present because they are C5 reflex. So absence of tricep reflex in a background of carpal tunnel like syndrome means you have C6-7 radiculopathy, right? The other important differential diagnosis of a numb hand would be syringomyelia. What happens in syringomyelia? You have your spinothalamic tract which are ascending up. You have your spinothalamic tract, right? They are going up. What they do is they ascend, say for example, two segments in Lissor's tract. You have Lissor's tract wherein once they enter a segment, they ascend up and then they cross over like this and then they go up, right? Similarly, you have your spinothalamic tract. The sensations, they go in from the ventral horn, they ascend up through Lissor's tract and then they go in the lateral spinothalamic tract, they cross over like this. So the crossing over is in ventral white commissure, and whenever you have a syrinx which gets enlarged, the first fibers which gets affected are spinothalamic tract. So your pain and temperature goes away. So patient will come to you with numb hand wherein he will be burning out himself with, and he will be having injuries over his fingers and he will not be able to know. So this is usually in C5 to C7 segment. So these are the hands which bear the consequence. Okay, so this is ventral white commissure, which is the first thing to be affected in syringomyelia. So this was the differential diagnosis of a numb hand. So just to enumerate, the first thing will be a carpal tunnel syndrome, the second would be a ulnar nerve, the third would be a C6-7 radiculopathy, and fourth would be syringomyelia. Right? Now we come to paraplegia. So suppose you have a patient who has, see, a 65-year-old male who has progressive quadriplegia or quadriparesis. When you say it is progressive, it means that it is not a vascular event. There is something else going on. So we will have different scenarios in this now. What happens and how do we localize a case of progressive quadriparesis? So suppose the weakness is fatiguing. If you have a fatiguing weakness, the case goes towards your myasthenia gravis, right? The most striking feature in myasthenia gravis would be you will not have any sensory symptoms. There will be no sensory symptoms. Your sensations are entirely normal. So anyone who has progressive quadriparesis, but the quadriparesis is fatiguing on frequent use, may be associated with diplopia, or it may be associated with ptosis. So the case without any investigation goes into favor of myasthenia gravis. Okay, always remember that fatiguing weakness is a hallmark of myasthenia gravis. Suppose on examination you have proximal muscles which are more predominantly involved, than distal muscles, and the sensations are intact, both posterior columns and spinothalamic tract. So this goes in favor of myopathy. Okay, proximal muscles more than distal muscles, all sensations intact. So it is not a spinal problem, it is not a nerve problem, it is a problem of muscles. So anyone who has quadriparesis, right, and has a weakness which is predominantly in proximal muscles more than distal muscles, and sensations are absolutely normal, your diagnosis is myopathy. Suppose when you examine a patient of quadriparesis, you find that the reflexes are absent. Reflexes are absent and you have atrophy. Means you have atrophy of the leg muscles and you have reflexes which are absent. So this is a case of lower motor neuron type of quadriparesis. This is LMN. So where should be our lesion? The lesion could be into anterior horn cell, AHC. The lesion could be in the nerve root. It can be in the plexus. It can be in the peripheral nerve. But it won't be in the neuromuscular junction, because LMN means anterior horn cell, nerve root, plexus and peripheral nerve. Neuromuscular junction and your muscle is not a part of LMN. So once you have absent reflexes and atrophy, you have to fit your lesion here, either into anterior horn cell, nerve root, plexus or peripheral neuropathy. So again, can it be anterior horn cell? Yes, it can be. It can be a case of polio. It can be a case of polio. Again, the sensations will be entirely intact. You will have lots of fasciculations. It can be amyotrophic lateral sclerosis, ALS, early case wherein you are having just LMN features. You don't have UMN. You can have LMN features. So early amyotrophic lateral sclerosis can present to you with anterior horn cell involvement. Can it be nerve root? Yes, it can be. But the nerve root will have shooting pain component. It will have shooting pain. Nerve radical or nerve root pain is characterized by electrical sensations which are very difficult to manage. So you have nerve root pain. Can you have plexus? See, bilateral lumbosacral plexus can be involved in autoimmune conditions or some infectious conditions also, but it is very rare that both of your lumbar plexus, lumbosacral plexus are involved, but it can be a possibility. Again, you will have predominantly sensations which will be impaired, or you have dysthesias or allodynia. Can you have peripheral nerve wherein the reflexes are absent and atrophy can be present? Yes. You have motor neuropathies. You have motor neuropathies. Say for example, where you have decreased TSH, thyrotoxic motor neuropathy. You don't have any sensory problem. The only problem is quadriparesis. So whenever you encounter a patient where the findings are in favor of lower motor neuron, try to fix your lesion in these four: peripheral nerve, plexus, nerve root and anterior horn cell. It applies for your upper limbs also. So we are just taking an arbitrary example of lower limbs. Suppose this patient comes to you with shooting pains in both legs. He has atrophy and he has absent reflexes, but he has shooting pain in both. Can it happen with a disc? Highly unlikely. Highly unlikely. Shooting pain in both legs means you have to have a lesion wherein most of the nerve fibers are getting involved. So where are the nerve fibers, compacted nerve fibers for the legs are? They are in the caudaequina. So anyone who has atrophy in both legs and absent reflexes with predominantly shooting pain in both legs, you have caudaequina lesion. Remember, when you have demonstrated clinically that we are dealing with probably a caudaequina lesion, you need to screen your lumbosacral spine, not thoracic spine, because caudaequina is below T1. You have all the nerve fibers which are coming down. So you screen your lumbosacral spine for caudaequina. Okay. Now suppose this patient he comes to you with left leg which is weak, the plantar is extensor, the reflexes are brisk in left leg. So we have a patient of weakness in lower limbs, but he has in his left leg paresis plus upper motor neuron type of lesions, and in the same leg you have vibration and proprioception which are absent or decreased, while in the other leg, right leg, the pain and temperature is diminished. So this is slightly difficult to understand, that in left leg you have weakness and upper motor neuron features with vibration and proprioception lost, and in right leg you have pain and temperature. So unless and until we understand the anatomy of the spinal cord, it will be very difficult for us to understand this. This is your anterior horn cell, anterior gray horn. This is your ventral horn. Laterally you have corticospinal tract, Here you have spinothalamic tract, and here you have gracialis and cuneator fascicle, right? So you have your posterior column sensations going right in, they are not crossing over to other side, and there is no synapse, here, and goes up, right? These are large myelinated 1A fibers. Then you have spinothalamic tract, for which it goes in, ascends one or two segments as a Desors tract, right? And then it crosses over like this, right? And then you have corticospinal tract, which have already crossed at medulla, right? And it goes down and supplies your respective anterior horn cell. So suppose this is the left side, this is the right side. You have a disc, or a tumor or an abscess which is compressing the spine from left side. What will happen is there will be swelling in the cord. Whenever you have swelling in the cord, this corticospinal tract will go, the spinothalamic tract will go, and your posterior columns will go. So just by understanding that this is spinothalamic tract is coming from right side. So whenever you have left-sided involvement, you have left-sided corticospinal tract involvement giving rise to the pyramidal signs. You have left-sided posterior column involvement giving rise to vibration and proprioception loss. And you have the opposite side spinothalamic tract involvement giving rise to pain and temperature loss. So this is Bronzicard syndrome. So Bronzicard syndrome localizes only to spine. Okay. Usually this is known as hemisection of spinal cord, but generally you don't find hemisection of spinal cord. You generally encounter a case of external compression which gives rise to swelling in the cord and thereby leading to all the tract involvement. Suppose the same patient of quadriparesis gives you a history that he has pinprick sensations and numbness in both hands and feet. Pinprick sensation and numbness are hallmark of peripheral neuropathy. So we are dealing in the case of peripheral neuropathy due to any cause. Say for example, patient has diabetes. In diabetes, you have early involvement of unmyelinated small fibers giving rise to spinothalamic tract symptoms. Either you have dysesthesia, hyposthesia, allodynia, whatever, right? So this is because of small fibers which are unmyelinated. Later on, you have your motor system which gets involved, motor fibers, that give rise to paraparesis or quadriparesis. So whenever you have predominant pinprick sensations and numbness, in a case of quadriparesis, we are dealing with something like peripheral neuropathy. Suppose you have decreased vibration sensation in legs, bilateral plantars are extensor, and decreased pinprick in both hands. Mind you, the patient comes to you with paraparesis, that is legs are weak, and you have demonstrated that the vibration in legs are also lost. You have bilateral plantars which are extensor, and you have decreased pinprick in both hands. So this goes in favor of subacute combined degeneration of cord due to B12 deficiency. Why B12? Because B12 is required for myelination. You have large myelinated fibers in the posterior column, they get demyelinated, so you have symptoms of posterior column, right? Spinothalamic tract, it gets involved later. It's a part of peripheral nerve which are involved, spinothalamic tract, right? Bilateral plantars are extensor because corticospinal tract is also heavily myelinated. So you have demyelination of corticospinal tract, so thereby you give rise to various outcomes of pyramidal findings. You can have increased DTR, you can have increased plantar. So in a case of B12 deficiency, you have a plethora of symptoms and signs, right? You have a combination. You can't have a single lesion. So the differential diagnosis zooms down to subacute combined degeneration of cord. Suppose you have, in case of quadriparesis, you have atrophy, you have fasciculations, you have DTR which is increased, you have clonus, and you have mild weakness in arms also. In arms with fasciculation. Always remember, once you have fasciculations, we are saying anterior horn cell, anterior horn cell, anterior horn cell. So this is a classic presentation of amyotrophic lateral sclerosis, a mixture of upper motor neuron, your cortical neurons, neuron cell bodies have degenerated, giving rise to upper motor neuron findings. Then you have anterior horn cell which are involved, giving rise to your element findings. So right, so this is the way we try to fit in a lesion in a case of paraparesis. Now coming to quadriparesis, say for example you have a patient who comes to you with subacute quadriparesis. Now you demonstrate that you have decreased vibration and DTR is absent. So this is definitely a LMN problem, a lower motor neuron problem, wherein the DTR is lost, plus there is posterior column involvement, that is demyelination is happening. So one of the most important cause of demyelinating posterior columns and LMN findings would be GBS. So always remember, acute to subacute quadriparesis, wherein your DTR are absent and your posterior column sensations are gone, you probably are dealing with GBS, right? Suppose the same patient of quadriparesis comes to you with DTR which are increased in both lower limbs along with clonus. In arms, the tricep reflex is increased, and bicep and brachioradialis are lost, and there is radicular pain in both arms. So you have quadriparesis, you have radicular pain in both arms, you have upper motor neuron findings in both legs, your tricep reflex is increased, and your bicep and brachioradialis are absent. So there is some problem in your neck. There is some problem in your neck. So this is cervical myelopathy. What is causing this cervical myelopathy? Say, if the lesion is at C5, if the lesion is at C5, the compression is there from outside, the corticospinal tract at C5 will be compressed. So this will give rise to your LMN finding at C5. Bicep and brachioradialis reflex are C5 reflex. So that goes away. But anything below the lesion will be UMN. That is the reason you have clonus, you have increased DTR in both limbs. This compression will cause involvement of your nerve roots. The nerve root impingement will cause shooting radicular pain in your both arms. Right? So this is how you can establish whether patient has cervical myelopathy due to any compression or not. So by this we end our neurological treatment of lesions. We'll see you in next lecture.